Okay, well, good day, everyone. And I think we'll go ahead and get started here. My name is Ryan Hennon. I'm Vice President of Sales at Optellum. Thank you all for joining, especially thank you, Dr. Vachani and Dr. Bellinger, for joining us for today's interesting and engaging discussion about lung nodule, incidental lung nodule cancer prediction, and using some of our newest tools, which are AI based. So again, thank you for everyone for joining. We'll jump into the introductions here and I'll give some background. Just forward there we go. So for today, and my apologies, I do see that there are a lot of people actively joining. They may miss just a snip of this, but from an agenda standpoint, again, myself, I'm Ryan Hennon. I'm the Vice President of Sales for Optellum. Joining us, we do have to start the webinar presentation, Dr. Neil Vachani from UPenn. We'll first give an engaging presentation, followed by a few questions from the audience. If very limited time, unfortunately, but we do have we'll try to reserve a solid 5 minutes for questions. And then Dr. Bellinger will come front and center, Dr. Bellinger from Wake Forest Baptist. And she has an interesting presentation to share with us as well, with some of this world's first FDA cleared technology that we'll be discussing. And again, we'll reserve questions at the end for the audience. I would invite all attendees, as the presenters are going through their presentations, to actively and proactively ask their questions, because again, when we have very limited time, and there will be a lot, so we need to administer them and get them to our presenters as quickly as possible. So thank you for that. So thank you again, Anil and Christina, for your help here, and we're really, really excited to hear what you've got to say. Just as I'd like to give one quick slide for background. The focus of today's discussion is, again, incidental nodules, and I thought it would be worth kind of sharing some of the background that we've got, at least as best as we can get our arms around it. The number of incidentals in the US is very high. So anywhere from between 1.5 to 2 million new incidents of nodules each year in the US. And that is with a growing and aging population. chest CT utilization is up. Post-COVID, CT utilization is up. And we find that for numerous reasons, more than half of these patients are lost to follow-up. And that can range from reasons of, it's not the primary medical reason that they're being imaged. From a technological standpoint, these nodules are not sometimes in the primary what they call problem list in EMR. So other things are being actively tracked automatically where the incidental nodule would not be. There are a host of communication problems coming or stemming from, an emergency room physician, an ordering physician, a primary care physician, a radiologist, a pulmonologist, interventional pulmonologist. There are a number of clinicians that have interest in this group, and sometimes it becomes a question of who's got the ball. And then I think importantly, and we'll discuss this when we talk about risk stratification, current methods and some new methods that we've got that are AI based. One example I think that is noteworthy is the benign resection rate, which is pretty standard. And I hear this in discussions from all types of healthcare organizations from around the country, that this number is high, and it's not, I wouldn't say it's an accepted rate, but there's not much we can do about this with the current risk stratification models and tools that we've got. So just some background that I thought would be relevant to kind of kick off and frame the discussion for today. So with that, I think I'll hand it to Dr. Vachani from UPenn, and he's got a presentation that he'd like to go over with us. We've got about 20 minutes for this, and we hope to have at least 5 minutes for discussion afterwards. So Dr. Vachani, thank you very much, and take it away.
Great. Thanks, Ryan. Hello, everyone. Delighted to be here with you today to review some of the data from this work. I'm going to go ahead and, am I sharing my screen, Ryan? I thought I was. Yeah. So it's, there we go. Now it's letting me share. Okay.
Sorry about that, Dr. Vachani. It was my share that was interrupting yours. So go ahead.
That's good. I think I'll probably ask you for the go ahead. Is that if you can see my slides now? Is that good? Is that visible to you?
Yep. Yes.
Okay.
You're good.
All right. So here we go. So I'm going to review the data on the LCP tool, or the lung cancer prediction tool that that's been developed by Optellum. My disclosure is here, which essentially says that I receive, or my university receives funding for the time I spend performing some of the work that's shown here, and some work that we're moving forward with in conjunction with Optellum. I just need to move a couple things out of the way here on my screen. So just a very brief background. The tool itself is as an AI or radiomics-based tool for lung nodule assessment. This particular tool has been shown in several multi-center retrospective studies now to have better nodule discrimination than standard clinical models, and the references are shown there. In particular, for the Optellum tool, it's the reference by David Baldwin and Pierre Messiaen and others. And then other tools have been shown to work similarly as well for nodule prediction, and there's some, reference 3 is one of those for further reading. What's not been shown, at least up until this point, is how these tools can impact the evaluation by radiologists and pulmonologists in clinical practice. And so the study I'm going to describe is actually more of an artificial one, where we did a reader study to sort of build the initial data for and evidence for moving this forward into a trial in clinical practice. So a very brief background on the lung cancer prediction tool itself. I'm going to use my pointer here to just point out that the tool itself takes an individual nodule and then uses the lung cancer prediction tool, again, this AI convoluted neural network-based assessment to create a lung cancer prediction score, which is presented to the clinician. And what's shown here on the graph in the bottom right corner is how the score is presented. It's been transitioned to a decile-based score. Each decile reflects a level of risk of cancer for that individual nodule. So for example, a score of 4 here would represent a 2% probability of being malignant. I swear I'm not doing that. I'm not sure why the slides are advancing on their own here. So we'll try and keep that working correctly. And then that score can then be used by the provider to alter their sort of individual assessment of lung cancer based on their assessment. The lung cancer prediction tool was developed in a very large data set, including NLST data. This sort of goes back to the validation studies done by David Baldwin and Pierre Messiaen and colleagues. Shown here very briefly in the bottom of the slide are 2 ROC curves that show that the LCP tool performed better than at least the traditional clinical risk prediction models that we use frequently in the United States. This is the Mayo Clinic model that it was validated against. And as you can see in both populations, either the Vanderbilt population or the Oxford population, there appeared to be some improvement. And it may have been a little bit better in the Oxford population, where the prevalence of cancer was a little bit lower, but seemed to work better than the Mayo model in both situations. So the study that we performed in conjunction with Optellum was what's classically considered in radiology a multi-reader, multi-case study. This is a design where you have multiple readers. In this case, we had 12 readers, 6 radiologists and pulmonologists, a varying level of experience. We then evaluate a case set or multiple cases of a particular indication. And in this case, our use case was 5 to 30 millimeter solid and semi-solid nodules, which were equally divided into 150 malignant and 150 benign scans. Each provider or clinician read the study. Oh gosh, I have no idea what's happening. Sorry. Each provider read each study before and after being presented with the AI tool, and I'll show you how that worked in just a minute, and then provided an assessment of risk based on those two assessments. So this is how the Virtual Nodule Clinic platform appears to the user. The nodule scan is provided, shown here on the left. The graph showing what the decile scores mean is shown here in the middle. The specific score for that individual nodule is presented here, showing an LCP score of 9. The provider is then asked to estimate their likelihood of malignancy. Again, they do it before and after the LCP score is provided. They also provide their management recommendation before and after the LCP score is provided. And in this case, at least in this exercise, they had to choose between these 5 choices for their management recommendation. So they could choose anywhere from choosing no action to a long-term follow-up, short-term CT follow-up, or to an immediate evaluation, including PET-CT, biopsy, a non-surgical biopsy, or a surgical resection. And I'll show you that data across these data points here in just a second. So the baseline study data is presented here. This is the data on the nodules themselves and the patient characteristics from those nodules. As you can see, it's sort of relatively balanced between male and female. We had this range of nodule sizes I mentioned from 5 to 30, most of them being between 10 and 30, which I believe is the most difficult place for providers to assess risk. Nodules included mostly solid nodules, so we had a sample size, 55 samples of part solid nodules, distributed also by speculation and by whether they were a diagnostic or a screening CT. So our primary endpoint was improvement in the area under the receiver operating curve, shown here as the AUC, without AI and with AI. So there was an overall improvement of AUC of about 7 percentage points across all readers, which was statistically significant. Here's a little more information on the readers themselves. So again, as I said, they spanned across radiology and pulmonology, various levels of experience, and various levels of training and clinical practice site. In particular, included folks who, pulmonologists who focus very much on just doing thoracic oncology, as well as a couple of radiologists who've done thoracic radiology fellowships and focus their work primarily in thoracic radiology. And if you look at the performance across these 12 readers, I've shown that here. So this bar graph shows essentially the AUC before AI and then the increase with AI for each individual reader. And so I think one interesting point is that all readers improved with use of the AI tool. Some more, a little bit less, and some a little bit more, but these were all statistically significant increases in AUC across these 12 readers. Some additional secondary endpoints, we then further assessed whether the readers become a little bit more consistent across their reads. We used the Fleiss kappa statistic, which measures consistency or variability across readers, both before and after the LCP tool. I've broken out the categories, sort of using the CHEST clinical guideline thresholds here. So very low, the low to moderate category, moderate to high, and then in the very high category, above 65%. You can see what the kappa statistic shows here before using the LCP tool and the kappa statistic after, and they all move in the correct direction of being more consistent in their interpretation of risk across all readers. And then the overall kappa goes from 0.36 to 0.58. Again, all of these results being statistically significant. We assess sensitivity and specificity, again, using the CHEST clinical guideline thresholds of 5 and 65%. And again, here you can see what the sensitivity was at that threshold, both without the AI or with the AI. So an improvement that was a little bit more modest at the low threshold, but perhaps more importantly at the high threshold, where we think that patients really move into doing more aggressive evaluations, including surgical biopsy. The improvement in sensitivity was about 10 percentage points with the AI tool. Similarly, data for specificity shown here on the bottom of the slide. Again, also significant at the 5% level and marginally significant at the 65% level for specificity. Another secondary endpoint was to assess whether the management recommendation improved or not, depending on use of the LCP tool for assessing both risk and then the subsequent management recommendations. So again, I put the 5 management recommendations that could have been chosen by the reader up here. And then just really on a dichotomous scale, sort of said that for the nodules that were cancer, whether the change was in the correct direction. So if a nodule was malignant and the LCP tool led to a reader going from, let's say, long-term follow-up to choosing to do PET-CT or biopsy, that would have been considered a correct change. And the other direction would have been considered an incorrect change. And then the net change is essentially just the difference between the two. So across the 150 nodules that were malignant, there was an average increase or improvement in terms of management recommendation in 42. On a percentage scale, that was 28% improvement. Similarly, you can see that for the benign group, there was also a net improvement in decision-making, though less so than compared to decision-making for nodules that were malignant. Finally, let me show you a couple of examples of how this tool worked in 2 of the examples from this study. So this is a malignant nodule shown here across 3 different CT views. The initial physician provided likelihood of malignancy on average was 38% before using the tool. With the LCP tool, it was 74%. So an improvement for a malignant nodule. And then I've just provided 3 selected examples of how the management recommendation then changed along with the increase in the AI assisted risk assessment. Similarly, for a benign nodule, again shown here across 3 different views, the risk assessment without AI was around 52%, dropping to a mean of around 20% with the LCP tool. Again, 3 selected examples of how subsequent management recommendations also improved with use of the tool. So in summary, I think that the data here suggests that the Aptelum LCP improves the ability of radiologists and pulmonologists to accurately classify indeterminate pulmonary nodules as malignant or benign, regardless of their experience. This was 12 readers, split equally between radiologists and pulmonologists with various levels of experience. Certainly, it would be important to see this done in clinical practice and what we see in terms of the breadth and variability that we know occurs in risk assessment, and show that this tool works similarly in that regard. And I think Christina will speak a little bit about that shortly around how this works in practice. The LCP tool improves inter-reader consistency based on the kappa statistic data that I showed earlier. And at least at the ACP threshold guidelines of 5 and 65%, it improves sensitivity and specificity. We've actually done this for the British Thoracic Society guidelines as well, at 10 and 70, and I didn't show that here, but the effect was similar. And I think that we can say that we think that the Aptelum LCP will have a meaningful impact on subsequent management recommendations, at least in this somewhat artificial environment of doing a multi-case, multi-reader study that appears to align with an improvement in risk, that the management recommendations also align better with whether the nodule is malignant or benign. But again, I'm sort of excited to sort of see what the next steps will be to see if that's true in practice as well. So I'll stop there. I think I've actually finished a little ahead of time, so we have time for questions. Ryan, if you want to raise any. I haven't been following the chat, so I'll see if
thank you very much. Thank you very much, Dr. Vachani. That was really quite interesting. I've got my own bunch of personal questions, but I'll go right to the chat because we're getting a flurry. Just for starters, can you give an overall kind of impact statement? I mean, as director of a pretty well-known lung cancer center. What do you look to? Let's make sure I'm getting this from the chat right. What do you look to for the future? Knowing, I mean, you're seeing what looks like impact on clinical decisions, next steps. What really excites you when you think about what your data shows when you apply that to clinical, and you haven't, but when you apply that to potentially a clinical setting like your own, what do you see, or what are your hopes?
Well, I think, you alluded to this at the beginning of the presentation, which is that I think we pretty well recognize that the decision-making that we see sort of across the board in pulmonary nodule management is challenging, right? There are nodules that are in the size range, in particular in the intermediate risk range or the indeterminate risk range, whether we believe that's sort of 5 to 30 or 8 to 30 or whatever people believe is the most challenging range. We know that estimating risk using both physician intuition or physician experience or with risk prediction models, has its limits. These models or our own intuition are far from perfect. And it's frequently difficult to tell whether a nodule is malignant or benign based on CT appearance alone or based on what we commonly use, which is size and speculation largely. And so the fact that there is a tool like this that can be assessed based on the scan itself, that is data you already have, I think is exciting. It does not require getting an additional blood draw for another test. It doesn't require getting a PET scan and waiting for that result, which may or may not have value, again, depending on sort of the prevalence of disease and issues like granulomatous disease prevalence in your local environment. PET scans can be a little bit challenging to interpret. So I think that the fact that this can be done and done immediately with the data you already have and improved decision-making is what's most exciting. And I think what, at least for the future, I see the next steps being seeing how this works in practice. I think that is the next step. I think that the data from Dr. Baldwin and Dr. Massione prove that this works from a validation perspective. Using existing data sets, this shows that providers can use it and use it well and improve their decision-making in an artificial environment. And now we need to go out and show that it works in actual clinical practice.
Very good. Yes. Okay. Thank you for that. And we are getting questions that continue to file in. What I think I may do is we'll probably turn the presentation out. Let me introduce Dr. Bellinger, and what we will do is we'll take some time now and reserve additional time on the back end for questions, because I think they're still coming in and Christina hasn't even started yet. So let's see, I'm going to take over sharing if that's possible. Yes. And let's get down to, my apologies here. So here we go. Right. You can all see my screen, I hope. I think I've got video, audio, and sharing. Okay. Let's get to Dr. Bellinger. Very good. So thank you, Dr. Bellinger, for joining us. Dr. Bellinger from Wake Forest has some related discussion on incidentals and her experience with new AI technology. And I believe she's going to touch on the tracking and management of these patients as well. So thank you again, Dr. Bellinger, and please take it away.
All right, thank you. I can share my screen here.
Yep, there you go.
All right. All right, so disclosures, I don't have any financial support for this talk or use of the platform. I was part of the study survey that Dr. Vachani just talked about, and I certainly have future research projects planned with the platform. So as an overview, like Ryan mentioned, I'll talk about Optellum as the use of patient tracking, using it for lung cancer prediction, and give you some early case examples. So before we started using the Optellum Virtual Nodule Clinic, which we've been doing for several months now, We kind of had no real dedicated patient program to manage incidental nodules. It was up to the physician whether they tracked it on a spreadsheet or by hand or just hope that they followed up because they ordered the scan. And patients are fairly spread out. To General Pulmonary Clinic, we do have a dedicated nodule clinic, but it's hard to lasso all the patients into nodule clinic. And then we also have a pulmonary thoracic oncology program clinic specifically for larger nodules or adenopathy that need more immediate attention. But our overall challenges was that it's difficult to know if patients no-showed without having a way to track them. We also didn't have a way to remind them if they didn't show up. And the tracking was pretty haphazard. Like I mentioned, maybe there was a note in our electronic medical record. Maybe we did it on an Excel spreadsheet. Maybe we did it on paper. After using the nodule clinic, we started entering patients into the system, and we have it separated into different physicians. So physicians have their own platform where they can see specifically their patients, which of their patients didn't follow up, which ones had a follow-up CT scan and now it needs to be reviewed, or if it's green, you're good to go and you have time. So those reminders are extremely helpful. We also, with the platform, can see patients' reports directly, view them directly, pull up the previous report and compare, go straight to the nodule that we marked previously and compare it to the latest scan. So our kind of workflow, now that we've had a few months to use the program for nodule tracking specifically in management, is a couple times a week we may log in. Login's pretty simple. I just keep it on my desktop, and I can review the virtual nodule dashboard to look for patients, see if there's any patients marked that missed their follow-up, or patients marked that I have a CT scan that's new that I need to review. From there, if they miss their follow-up, I can send a flag to our office assistant to get the patient rescheduled. In our clinic, so for new patient visits, I have the option to either pull up their scan ahead of time and load it into the Optellum platform, or alternatively, I can do it during clinic. I just keep the link in one of my notes to myself in the electronic medical record, and then wherever I am, I can open it up and add it from there. And that lets me track the nodule, mark the nodule, and then know what my clinical decision was at that time. So all of this ideally would be done with the support of a navigator who would do this in the background for the physician, potentially load them up, and we're working towards that. So the benefits, and this is again just the tracking part of it, is that we have a little bit better peace of mind that patients aren't falling through the gaps in care. And we did go back and look. So just in my virtual nodule clinic alone, I had 5 patients that we had to send reminders to. So I have the peace of mind of knowing that those patients didn't fall through the cracks. It is centralized, so I can see my last decision. I can see the current decision that I'm making. I can line up my nodules side by side for comparison. I also get alerted if a patient had a CT scan. So if I open up my virtual nodule clinic, it will let me know if a patient, say, went to the ED, had a CT-PE study, and now there's a scan a month ahead of time that I can review and then potentially can bypass needing that follow-up CT scan. And then for the peace of mind for the patient, they can receive the appropriate follow-up and not follow through the gaps in care. So in the end of May, we went from just using Optellum as a nodule tracking platform to using it to help our decision support with nodules. So I did mention these will be some early cases that I'll go through because it's just that brand new. So you already saw this screen in the last talk that sort of shows what we see on the clinical end. We mark our nodule, we get our lung cancer prediction score, and then ultimately we see a chart similar to this in the virtual nodule platform. So we have the option in practice. We can either do it just like the tracking software, we can do it before clinic or even during the clinic. And just like I mentioned, we see it directly in the Virtual Nodule Clinic. It is one click over the nodule. We don't have to go to multiple views. It really is just that single view that you saw where you click the center of it. The software platform circles the nodule, and then you get the report. I also left off of here, but you can generate a PDF. So if I want to generate a PDF of the report of what the lung cancer prediction score is to go in the patient's chart, I can do that. All right, so I'm going to go over 2 case studies. This first one is a 79-year-old female, has a left apical 16 millimeter nodule. That should be left upper lobe. She's a smoker, 1 pack year. We did in clinic. This was before we had Optellum lung cancer prediction. Ran the Mayo, and it was 27% versus ranging from 27 to 47, depending on if the patient was considered a smoker with that just small pack year. And then the Brock nodule calculator at 36%. So we had discussions with her in clinic about all of her potential options, TTFNA versus navigational bronchoscopy. I don't show the image there. You could see an airway going to it in other views, though it's small and apical, so difficult to get to, versus potentially a PET scan. Ultimately, she opted for navigation bronchoscopy with endobronchial brushing genomic classifier. Her navigation results came back as focal chronic inflammation and fibrosis with no granulomatous inflammation. We did the genomic classifier. I put her pre-procedure risk as intermediate. For those of you that have used genomic classifiers, the Veracyte Percepta test, you mark whether it's low, intermediate, or high, and then you send off the bronchial brushers to the company, and it comes back low, intermediate, high, or very high. Her post-test scoring after running the bronchial brushes was intermediate, which is 10 to 60% likelihood of cancer. So it just gives you that range. So it didn't change our risk there. We brought her back. We discussed PET scan. She definitely wasn't comfortable with more conservative management. So really was PET scan versus empiric radiation. But before we did any orders, the Optellum prediction score platform went live. So we did her nodule, came back at a score of 5, which you can see is 5.6% likelihood of cancer. And so we all felt much more comfortable about getting a follow-up interval 3-month scan. So like I said, these are early cases, so I don't have that 3-month scan yet, but we're happy to report back what we do and what those results are. So case study number 2. So this was a 65-year-old female incidentally found 10 millimeter nodule in the left lower lobe. She's a 40 pack year smoking history. The nodule calculator, so Mayo came back at 1.9, Brock came back at 11. Again, we started our initial discussions before we had the Optellum score. So we initially discussed a follow-up scan in 6 months. When we went live, I ran the Optellum score, and it came back 9 at 84% likelihood of malignancy. She, after discussions, had wanted to be aggressive from the start, and so we had talked about follow-up scan, but with the results coming back at higher probability of cancer, she became very interested in CT surgery resection. So she has her surgery appointment coming up. So I think these 2 cases kind of highlight our excitement about the platform and what we hope to see. I think it will make clinicians and patients more comfortable in whatever clinical decision is made, whether that's a follow-up imaging or a biopsy. I hope to see us use this in the decision-making with the patients. It's been well received in the very limited numbers of patients who we've discussed it directly with as a nice education tool in the era of shared decision-making visit about all patient care, it can be very helpful. For indeterminate nodules, which is what we see so much of, we often see that they're just difficult to reach by biopsy. I think you saw that in the 2 cases I showed you. And so hopefully this will help us know when to be more aggressive and when to be more conservative. I think also, not all of these patients can get into thoracic oncology programs. So it can be helpful for non-specialists and less experienced clinicians. And then enhanced discussions in a multidisciplinary format. So I put that on there because we are planning to present these cases and some others to our thoracic oncology program. We have a Friday noon meeting to bring awareness to it and potentially use it in the future for case discussions. And then hopefully help with the consistency of the clinical decision making. So takeaways, so 2 different but complementary uses for the platform. So nodule tracking, I think it is user-friendly after having done the survey training on it, followed by using it in real clinical practice. It's easy to mark the nodules, label them where they're at, compare them to the most recent scan. I'm excited to see a reduce in loss to follow-up patients or unnecessary scans. And then for the lung cancer prediction score, hope to see improved decision-making visit. I think all of this is really promising, and we certainly want to have studies where we follow it in real clinical practice and see the difference. We can incorporate this into shared decision-making visits like the sample that I showed, reducing time to intervention for high-scoring nodules, or reducing unnecessary scans or biopsies by increasing interval follow-up in low-scoring nodules. All right, I will stop sharing my screen so we can go to questions.
Great. Fantastic. Thanks, Dr. Bellinger. That's, I'm gonna turn my video on here. Nicely done, and I love your background. That's very, very cool.
Thanks.
So we've got a few questions trailing in, and thank you for the time that you made in getting through the presentation. There was some good information in there. Back to how you opened when you discussed, you made mention of a spreadsheet. This is something that I do daily. And frankly, when I came into this, surprised me that there were so many different variations of, in a healthcare tech environment, really, when you talk about things about EHR and digital transfer of information, and now even EHRs are sharing data across what used to be known as competitive healthcare landscapes. We still find a lot of manual work. And I will say it's some people understanding that, knowing it is very manual, just can't do it, right? So going from there to where you are now, where we've got some semi-automation and sometimes potentially full automation, couple that with one of the data points that I led with about growth, and I don't know if you're seeing it at Wake in particular yet, but growth in CT volume, aging population, post-COVID, people are coming back to healthcare now. The question was specifically, do you feel like this may be a tool that helps prepare you for not only just return to normal healthcare post-COVID, but things like, guidelines for screening opening back up, wider adoption, better follow-up technologies that are unrelated to our own, that maybe inspire primary care to be more on the patient to follow up with these sorts of incidentals? So do you feel like this can help, or are there this and other measures you're taking to kind of prepare for this wave that we feel is coming?
Yeah, I think the number of lung nodules, like you mentioned in the beginning, is enormous. The volume is daunting, and we have a few things in place. Certainly for our separate screening population, they have navigators in place and upload to the ACR. When it comes to these incidentally found nodules, we certainly worry that with the rise in CT scans, that we are going to miss opportunities with making sure patients don't fall through the cracks. So I think this is one way we're a step in the right direction for following these patients. That just absolutely needs an incidental nodule navigator. So I think that's the next step in escalation, to not capture just individual physicians and what is referred to us, but just institutional wide catching all of these nodules. I know our ED has navigators in place to send letters to primary care providers for incidentally found findings on CT scans. But I do think institutionally wide, having specific nodules for incidental navigators for incidental nodules is going to be a key component. And we did look a few years ago, we just ran a query in our medical record to see, well, how many nodules are out there in our system. And so we ran it over a 6-month period for how many times the word lung nodule came up in chest imaging. And it was 8,000 in 6 months. There'll be some repeat patients in that, and
Wow.
some that are already followed. But yeah, I think the number is daunting, and I think we need something, platform like this, but we need the administrative staff to also make sure that the patients get uploaded so that they can get timely follow-up.
Fantastic, thank you. Another question for Dr. Bellinger before we open it back up to the kind of the full panel. So this comes in, so this is a question about the actual interface, it sounds like. So selecting the region of interest, is this something that the physician, and I'm reading the question here, does the physician have to select the radiographic region of interest? Is the lung cancer prediction model validated for semi-solid nodules? So maybe, Christina, can you take the first question, and I'll put the second component of validation to Anil.
Yeah, we do want the clinician to be the one to mark the nodule, and that way you're marking the nodules that are of interest to you based on size, shape, and other criteria.
Yeah, thank you. And just from my personal experience with speaking to nurse navigators, thoracic surgeons, pulmonologists, radiologists, in some cases I found it could be a nurse navigator interacting with the software on kind of a preparatory status. So getting things ready, or at some points just clicking the nodules ahead of time so the clinician does not do the ROI selection or goes through in like a confirmation mode of, yep, this nodule, I wanted this one, I did not. So Anil, can we have your opinion on the semi-solid question? And I'll reread the question here for a second. So it was specific to, is the lung cancer prediction model validated for semi-solid nodules?
Yeah, it's a good question. So the development of the tool included NLST data as well as other data that included semi-solid nodules. The validation sets that were presented in those 2 publications I pointed out did include some semi-solid nodules, though. And so from that perspective, it's validated in that regard, and that both the development and the validation included those nodules. I don't know off the top of my head that I can quote the subgroup analyses for semi-solid nodules from the validation studies, but it's worth looking up. It's also true that in our reader study that I presented, that we included semi-solid nodules as well, and the improvement appeared to be in line, though our study was not a formal validation study, that the effect that we saw with the LCP appeared to be similar across solid versus semi-solid nodules. So, but it's a good question, and I think it deserves a little bit more discussion and data generation. But from what we can tell, it works similarly. The challenge, of course, without getting too long-winded, is that semi-solid nodules are more rare, and so they represent a smaller fraction of all these data sets. So it is a good question to raise.
Okay, thank you. I had a question come in regarding incidental nodules, and this comes up with every discussion I have, really, but both of your personal expertise on this could be helpful. How the systems handle referrals, so bringing nodules in from the outside. Patient gets referred into your nodule program from a sister, not necessarily a sister facility, but a partner facility that brings in their nodules with them. does the solution work? Is it the standard CD import into radiology packs and then you have access to them, or how does that work? And maybe Christina, could you start?
Yeah, we get if it isn't outside, most facilities North Carolina wide now, we can get it electronically sent to our PAC system.
Oh, good.
Yeah, so that we can have access to it that way.
Okay. Dr. Vachani?
So I think Christina probably has more experience using the tool clinically. I think that what I can say though is that, I mean, certainly our program is working towards a world where radiology image transfer can occur without having to have a patient bringing a disc from, for each visit, right? So we'd like to get to a point, and at least locally, we've worked with solutions with our sister institutions and private radiology providers so that we have abilities to transfer images in directly. And so then once that image then is in our PAC system, the LCP tool can be applied, similarly to that study as it would be to any study done in our own institution.
Okay, fantastic. Let's see. Got a question on, sorry, that's kind of half off my screen right now. So a question came in about changing the score. So basically, I think what this is asking, that the lung cancer prediction score, does it change? Can you change it? Just whoever's got some personal experience of that.
I would say I only having used it a few weeks. I haven't gone back and looked at a previous nodule and ran the score, and then a year later run the same nodule. So I think it's too soon to say.
Okay.
I agree. We don't have data on that just yet, but it's a good question for a study.
Oh, and also it looks like a question about charging for the AI score calculation came up. And I know this is hot in the industry right now, and just from my personal exposure and experience, we seem to be approaching a time when this is becoming reality. I know the first in radiology for stroke triage as an AI tool now has the ability for a particular CPT code, but it's very specific to stroke triage. And I know all the vendors are racing to kind of use that as a predicate device, and they're all doing a lot of work regarding proving better outcomes and lower cost, especially to healthcare providers or payers. So I know that's coming, but I don't know if either of you has given that any personal thought.
Yeah, I think it's going to be a CPT code we'll eventually need, but we don't have a way to bill it right now.
Right. Yes. Agreed. Anil, looks like yes.
Agreed.
Let me check. Excuse me. One more look at the chat. I think. Okay. We do have one I need to go back to here. So this looks like, let's see. We did answer that one. Okay, all right, this one came out. Answered that one. I'll just ask the moderator here to repost this question because I think it actually came across as answered, and I want to make sure that we do answer it. Okay, all right, here it is. So to the panel, how do you find using the software in clinical practice? Does it increase the time spent in evaluating each patient? Is it more appropriate post-patient in the clinic, or can you describe kind of, and this sounds like it might be a Christina question about where and when and how the software utilization is, where does it take place? I thought there was some interesting data about how your patient had reacted differently, knowing that there was an AI solution that was arguing with an earlier clinical decision. So.
Yeah, I mean, right now it's not a strict protocolized format. I have a general pulmonary clinic where I work in nodule patients, and that one is very busy and typically overbooked. So I'll often come back to the patients. That's a lot of return visits and return nodules. Our thoracic oncology program clinic, I have more help with. There's typically a fellow there, so we're seeing patients side by side. So that one I like to pull it up during that clinic so that I can get the results um, right then and potentially include it in the patient discussion. Most of those nodules, I will say, are in the high category, and they're sent to that clinic because they're probably going to go on to biopsy. So there's only a few patients in each of those clinics that would actually enroll in the nodule program.
Sure. Thank you. I'm just reading the next question. Sure. I'm losing some of the spirit of this question. Sorry. I want to make sure I can get it clarified for you guys. Oh, I think this is a question about how maybe the automation works, and I can answer part of this, and maybe Dr. Bellinger or Neil, if you could confirm. So the question came up about how you find these patients. So how are these patients found? So the solution from a technical perspective is interrogating radiology imaging reports, finding a descriptor that both parties agree that included as a candidate for an incidental nodule, and that process is automated. Dr. Bellinger or Dr. Vachani, if you've had any experience crafting what that inclusion exclusion criteria is at your particular practice, when would you like the optellum to raise the flag and say this is probably someone you should look at, and when do you not?
Yeah, so I'll go first. So right now we're working on that inclusion exclusion criteria and how to pull all those patients and who's going to follow them. So until we have a dedicated incidental lung nodule navigator in place, we probably won't pull all patients system wide. So where we're at right now is patients are either referred to pulmonary from their primary care provider, or they were found to have an incidental finding in the ED and then routed to our nurse practitioner, and then we see them in clinic that way. So right now it's still more manual. Somebody has already followed up on the scan and then sent them to us. But absolutely, we are working on the infrastructure to be able to pull patients just from their electronic medical record. Okay, where are the nodules and who is in need of follow-up?
Sure. Dr. Vachani, you have any comments, thoughts?
No, I don't.
Okay.
I mean, well, but maybe I do. So I guess what I would just add to that, I mean, I agree. I think that it can be, of course, used across the spectrum, right? But this question is largely one around, how to find the large population of patients with lung nodules who need management in general. And that goes a little bit even beyond the LCP tool, right? To how systems sort of devote resources to automation around finding patients with abnormal findings in the lung and frankly elsewhere. And I know that actually, and I think Avi Cohen is actually one of the attendees who's at Henry Ford, and it's my understanding that they are going to be using this system as well to do a little bit more of a population-based approach to finding people with lung nodules, testing them across the board using the LCP tool to sort of optimize who should be sort of targeted for follow-up. And I'm very curious to see how their experience goes. And I think that Christina's thinking about doing that, and other centers are as well. This can also, without thinking about what it means to the big question, this can still just be a tool you use in your clinic for people referred for lung nodules, right? That's where the plan is that it should really start. This should be a way that you can then optimize that shared decision-making on one-on-one with the patient who has a lung nodule where you're having difficulty sort of determining whether it's concerning enough for intervention or not. And so I think it can be used across a variety of different practice settings with a variety of different approaches.
Sure. Fantastic. And I'll summarize into a couple people's questions that did come out as far as just the feedback in your institutions, or the reaction, maybe is the better way to say it, to AI being in your environments. I'm getting questions like, what do the other pulmonologists think? Do the thoracic surgeons know? Did radiology maybe adopt AI sooner? than pulmonology, so they're better with this, or did you have an ally with them, or is it some sort of other administrative goal to adopt AI technologies for better efficiencies or better outcomes or risk mitigation or whatever it is? Does anyone know outside of the pulmonology department that AI is making its way around, and have they had any reactions or provided any feedback?
Yeah, so at Wake Forest, Reggie Munden in radiology was the one that led us down this path. And so their department is aware. I think their only prior experience was a CAD system, nothing like an AI for lung nodule interpretation. And as far as awareness of other pulmonologists, it's been well received in our department. People are excited about it, looking forward to it, want to know how they can get trained and get it up and running so they can use it in their clinic also. Even the fellows, we have 12 fellows, and they definitely want to know more about it and learn how to use it as part in their fellowship training. So that's been well received. And then our next step is in a few weeks on one of our Friday thoracic oncology meetings to present it there, be able to give some case scenarios as well, and see if it's something that can be incorporated into those discussions.
Fantastic. Dr. Vachani, and this will probably need to be our last question here because we're getting close to wrap up time. But Dr. Bellinger mentioned fellows. So I have to ask, because this came up earlier and I was not going to ask it, but I think it's appropriate. How do you see AI in the future of training residents and fellows, and this particular nodule-based AI, where you can hit a magic button and spit out a number of what's the probability of malignancy for this nodule? Do you see that as in a blinded and non-blinded environment? But when we're talking about fellows and residents, these are our brightest stars that we hope to set loose on cancer in the US and around the world, really. So how do you feel? Have you given that any thought about university-based AI adoption because of the medical student population there?
It's a good question. I think what I would say towards its effect on training is that, this is a tool just like any other that provides a risk assessment, right? So I think it's still, of course, critical that providers, clinicians, physicians use that knowledge of risk to then translate to appropriate decision making. And so that art still remains to be learned, right? Whether it's by a medical student or a fellow. No tool is perfect, and neither is this one. I think this tool is better than what we have currently, which is why we believe in it and are studying it and are implementing it. But the fact is that we still have to interpret risk information and make good decisions, and that's still something that young physicians have to learn how to do.
Fantastic. Well, 2 minutes left in the hour that we can give back to our panelists and our attendees. So I'll take just 30 seconds to say thank you again, Dr. Bellinger, and thank you again, Dr. Vachani. Great presentations. We really appreciate all of the great folks that we had attending and asking really good questions. I apologize that we did not get to all of them. My name, if you'd like to outreach to me directly, is in my email address. That's right on the bottom of my screen. And our administrator is also making a note of all of the questions that did not get answered. And I will try to personally follow up at some point here this week. So thank you again. And that was a wonderful webinar and presentation. And I personally had a really good time. So with that, I will end the call, and everyone have a great rest of your week. Thanks and bye-bye. Thanks, everyone.